Good afternoon and welcome back to our C-Level Perspective webinar series. My name is Olivia. I am the Senior Manager of Brand and Communications at Kontakt.io. Today's webinar will uncover the dynamic changes in healthcare systems, and we'll talk about the strategies for addressing nurse duress and burnout and how to make a compelling case for digital transformation. So joining us today is the Honorable David J. Shulkin, former Secretary of the VA. Dr. Shulkin is also one of the best-known healthcare leaders at many hospitals and health systems, and he recently joined Kontakt.io's Healthcare Advisory Board. And we also have Phillp, the CEO of Kontakt.io, and he will help us unpack all the important topics in a minute. If you have any questions, please enter them into the Q&A box, and we'll address them all together at the end of the conversation. And with that, I'll hand it over to you, Phillp.
Thank you, Olivia, and hi, David. It's an honor hosting this with you. I think we have a lot of content to go into, but only 30 minutes. So I want to dive right into it. I think with your permission, we've decided to cut the introduction of all of your accomplishments and kind of what you've been doing for healthcare and US healthcare specifically, looking at the VA, very, very short, but I want to pass the ball to you in saying, what keeps you going? What's been your journey? And take it from there.
Well, thank you. First of all, it's great. It's great to be with you. I appreciate the opportunity, and thank you for everybody who's joined in today. I think you're right, Phillp. Most people know me as the former Secretary of the Department of Veteran Affairs. I served in both the Obama administration and the Trump administration. And still to this day, I think I'm the last member of the president's cabinet to get a 100-0 confirmation vote in the Senate, just to say that I'm not one who does politics. I completely looked at this as public service and not as being on anybody's political team or having political loyalty. My loyalty was to help the veterans who had sacrificed and served our country. But I think I really define myself much more as a physician than as a government leader. I'm an internist, and it's the way I look at things when I wake up in the morning, that I'm there to try to figure out how to help people who are suffering or to keep them healthy. And I've been fortunate to have lots of different opportunities throughout my career to use those skills as a physician, mostly running healthcare systems. So before going into government, I was the CEO of a number of different health systems, and I've served as a chief medical officer of many academic centers. And so really have been very privileged just to be in a position where I've seen great healthcare delivered and teams always trying to get better.
Yeah, so David, I think, as part of the preparation, you were saying you're in Austin right now, you've been in California, New York, Washington, Boston, just over the last, couple of days and weeks. Let's start very high level. What are the key themes and topics that you discuss now in the position that you have when you meet these healthcare executives? What's currently top of mind, and what are the themes that you've distilled down from there?
I think just somewhat uniquely, because of the opportunities that I've had, I get to see healthcare from many different perspectives, not only as a provider, but have worked in payer environments, government environments, work in technology, and across a whole variety of different aspects of the healthcare ecosystem, including pharma, where many people who work in parts of the healthcare system are somewhat narrow in the view that they see it. And since I look at things really horizontally across the ecosystem, I often just make connections between the impact of regulation on business models, the impact of technology into healthcare environments, how payers and providers can be better aligned. So I find that it's really that cross siloed perspective that I think is what I spend most of my time doing, just sort of making connections for people.
And then when you talk and you meet, let's move, for a second to like the people, part of the providers that are part of the health system. what are their concerns? What are their worries that they raise and that they bring up to you when you engage with them in conversations?
I think almost everybody uniquely worries about uncertainty. And, it's hard enough to run a healthcare operation, a big provider organization, but when you're running it and it's constantly changing and you don't know what's next on the landscape, I think that becomes a bigger challenge for leadership. And so you have a changing regulatory environment, you have a changing economic environment, you have a changing competitive environment, not even understanding exactly who your competitors may be next year if you're running a healthcare system. And yet you still have all these fixed costs and the responsibility not only to your employees, but to the people that you serve in your community, your patients. And so it is a challenge to be trying to make decisions now when the future is increasingly uncertain.
Got it. So I think one of the things you've mentioned, uncertainty changes, is the workforce. I mean, I think the title and what we've sort of, wanted to phrase and kind of deep dive a little bit is uncertainty in the workforce. And I think, the change that health systems have gone through, over the last 5 or 10 years. When you think about the people who are actually, on the front line providing care to patients, what has changed, if anything? And I'm curious to get both, the take from the VA's perspective, but also outside, when we look about it holistically, non-for-profit, for-profits, but what are the workspace dynamics that you've seen sort of changing?
Something fundamental definitely has changed. And, I'm sure with everything that's complex, it's multifaceted, but I'm going to put the pandemic front and center. There's something about having lived through this pandemic, having put people away from each other for quite some time, that has fundamentally changed a large part of the workforce's perspective on what their relationship is back to their organization that employs them. And we've seen it in some people that have reevaluated at the end of their career whether they want to continue working as hard as they were prior to the pandemic, so they've gone into either retirement or semi-retirement. But we've seen it probably more significant in the younger workforce that really doesn't want the same things as past generations have, and really are looking for the ability to integrate this. I'm not going to call it work-life balance, but I'm going to call it a relationship with their employer that is more focused on meeting their needs than on the employer's needs. And this is not necessarily a value judgment on whether that's good or bad. This is just a reflection on there are more people who want to be working in a hybrid environment. There are more people who want flexibility, both geographically, but also in terms of what they're working on, but also the hours that they work. And so that shift, along with the demographics of the country getting older, requiring more healthcare resources, has been translated into workforce shortage situations where if hospitals and health systems continue to operate the same way, not get more efficient, the projections for this getting better are not very pretty. That unless something gives, unless people create more attractive environments to work on, there's just no way to increase the supply of the workforce in the way that we're projected to need them. So there is a fundamental change that has happened. What I think has not changed, Phillip, is that what employees want, what all of us want, are pretty much the same thing, which was true before the pandemic and will be true way after the pandemic. People want to believe in leadership, particularly people in healthcare. They want to understand what their organization stands for, what the values are, what the belief systems, and they want predictability. They don't want leadership saying one thing and then policies and actions demonstrate something different. So they want to understand. They want active, vocal leaders who talk about the values that they share. They want to feel security, and that's both financial security in a time that is increasingly financially uncertain, but they, like everybody else, want to be part of a winning organization that they believe that they see is going to be there for them and in the future. But they also want to have physical security. They want to know that in these times where people are coming into buildings and attacking healthcare workers, and there's employee on employee violence in many situations, they want to feel safe there too. They also want to understand that this is an organization that is trying to deliberately create an environment that uses and values their skills and competencies that they trained in. That means creating an environment where less of the administrative, sort of more task-oriented skills are being moved away from them, and they're being able to be valued at the greatest competencies that they have. And so I think everybody wants to feel that their organization's moving in the right direction.
What you've said, I mean, is absolutely resonating, obviously, with how I'm seeing it and what we are kind of exposed to on a day-to-day, working in the field with health systems and trying to address some of these issues. But before we go to tactical here, there is, I think, this statistics out there that is often getting quoted, which is, I think, 1 in 3 nurses wants to quit the profession. And I don't know, I haven't been long enough in the industry to know if that was a number that has always been around, like 10 years ago and 15 years ago, or if that is now sort of the reaction to some of that change. But when you dig deeper, and I'm quoting it out because I actually thought that was a much more insightful comment. And the research says, I feeling undervalued, and I think this is a McKinsey stat from earlier this year. Feeling undervalued is more stressful to nurses than work, which I let you comment on that for a second, but I think the level of appreciation that is shown, which I agree, I think that has changed across industries over the last 10, 15 years. It certainly holds true for healthcare as well. Or what's your take?
Well, first of all, let's put this into perspective. When you ask the general population of Americans how many people are happy at work, 80% are not happy. So I think that what we're seeing is healthcare catching up with the rest of the workforce, where it has become much harder to be a nurse, particularly in an acute care environment. The fact that there's understaffing puts additional burden on those that do come to work every day. The fact that there's only more and more work being piled on to people that are there, whether it's regulatory and paperwork and compliance and new policies, but also the patients that we're seeing in the hospital are sicker and demand more and are requiring both physical and emotional care. That those burdens are only getting bigger. So I think that when you look at this issue, whether it's nursing or anywhere else, you will see a large variation depending upon what that organization that they work for has begun to put in place or new programs to be able to address those needs. The institutions that invested in education, in training, those that have put in support systems that offer gratitude, that have addressed the sort of non-salary needs of their workforce by supplying them with support, such as EAP programs and other ways to be able to address the work-life issues that they're facing, have done better in terms of attracting staff, but also retaining staff. So this is really where leadership matters a whole lot. And we're seeing proactive organizations outperforming those that are sitting there just sort of watching this happen to them.
Let me double down on this. So you've mentioned and pictured some of the things, like the categories of what can we do to address it and change it. Turning this into like a personal question, if you were to become, again, the CEO of a health system today, with what you've seen and kind of that widespread of, perspectives and stories that you've collected, what would you do? What are the things that you would think should be implemented and should be addressed?
Well, I have to say, look, I've been doing this long enough that I have a playbook.
I don't want to put you on the spot. I know it's a question we didn't have.
Yeah, I'm not interviewing for a job, but my playbook goes back to what I originally introduced my introduction. I see myself as a provider, as a caregiver. So in every organization I have worked on, I've first put on a white coat and gone into that setting and actually worked practicing taking care of patients. It's not because I believe I'm the most talented physician in the world. I believe that it helps me become a better leader to understand what my colleagues are going through, whether the systems that I'm going to work to improve are actually working or not, how the patients are reacting to the systems. And it's very important for leaders to get close to the place where care is delivered, to be seen as a colleague of the coworkers, not as the executive who locks themselves up in the office, and understand, what happens both on the patient floor, in the exam room, but also in the cafeteria and other places where people are able to talk more freely about their concerns. And so you have to understand the culture of the environment you work on, and you have to address those needs, and you have to listen to a lot of people. Even using the example, when I was secretary of the VA, I would put on a white coat and take care of patients in New York City, and I would use telehealth and take care of patients in Grants Pass, Oregon. But more importantly, since I was the first secretary who was not a veteran myself, I knew I needed to spend time with veterans and their families and understand what it feels like and what they needed from the VA. And so that listening and incorporating their thinking into the executive plans and management plans, I think, is absolutely critical, especially now, given the stress that people are feeling.
Got it. Shifting topic and going into, I think one of the domains that we are covering and exposed to, and which a lot of our conversations, kind of centering around when we talk sort of the track. 1 in 4 nurses gets assaulted at work every year in the US. And as a response, one of our product lines is that we provide a portable staff safety solution that comes in form of a badge, right, with a duress button that allows you, both from a security perspective and from a nursing leadership perspective, to immediately locate and send response, and to implement that as part of a wider, call it, workplace violence prevention program. And I think this is a topic that doesn't matter whether you're the CNO, you sit in the CEO office, or you're a nurse coming to work every day. It's kind of on the mind of people, I think, at all sorts of different layers in the organization. People are looking at different vendors, looking at different things. From your perspective on implementing technology and implementing innovation at scale, both at the VA, but also at other health systems you have led and you have served for, like, what are the pedigrees and the recipients kind of for success to actually drive innovation into outcomes fast and effectively for the people who at the end need and benefit from that?
Well, I think you've identified a really important area. So one of the things I mentioned, people who go to work need to feel secure. There's no question about that. But I return to the topic that I am constantly coming back to, and that is leadership. people want to see that their leaders care about their employees, care about the patients that they serve. And when a leader rolls out a system, the community that is impacted observes that. Is this a system that is focused primarily on financial improvements? Is this a system that's focused on me to make my workplace better? Is this a system that improves the quality of care? Is this a system that improves the patient experience? And every decision that a CEO makes that rolls outside their office is going to be evaluated in the context of one of those criteria. When a CEO makes a decision, or it could be a chief nursing officer or a chief medical officer makes a decision to put a system in place to ensure that their employees feel safe, that is one of the things that is noticed and people understand. That says a statement about how important they are in the context of all these decisions that are being made. In terms of your question about how do you roll these systems out so they're successful, we've all seen implementations of technology that have been dreadful, and we've seen some that have gone well. It is about the clarity of the message, why this is important, making sure that there are people accountable in the organization to make sure that those projects are implemented, making sure that there's clarity of a timeline, and making sure that the appropriate resources are allocated to be able to ensure that that timeline can be followed. But I think also most importantly, especially anything that involves the clinical environment, you do need clinical buy-in. And clinical buy-in comes when people are transparent. They explain why they're doing something, why it's important that it be done, and what that is going to entail, whether it's going to entail more work on the part of the clinicians, whether it's going to entail some time to get used to the new systems, or whether it is going to be something that's seamlessly integrated into the workflow and environment. But it all starts with clarity about why you're doing things, clarity on how it's going to get accomplished, and then clarity along the way about how it's going, the feedback. Are we on target? Are we off target? What do we need to do to get back on target if we've fallen off target?
Yeah, and it's really, you've already answered kind of part of my next question, which is we have a lot of people, that are listening to this conversation right now or later on in the recording that are, directly impacted and that carry the responsibility of coming up with these, new initiatives and ideas, and then winning, stakeholders over for, hey, this is something that I want us to address because of the benefit it provides to patient care and to overall staff safety and well-being, and because of that to all the rippling effects that have then financial impact. And we always get the question, which is, how do I build a very compelling business case? What have other health systems done, right? I know you've addressed some of that already, but I'm just kind of putting it out, again, anything that you want to add to that question, what would be your advice to sort of the listeners that are joining us today?
As I mentioned, there are projects that are done for financial return on investment. There's no question about that. Those are the easy ones to build the business case for. How much it's going to cost, how much revenue you're likely to get. You can make a calculation. Many institutions have criteria, thresholds that they only do projects that will give a 2-year or less return on investment, whatever your capital and operational criteria may be. But this often gets challenging in the other areas where you have a project that improves the quality of care, or you have a project, for example,
safety.
that improves
we can all go into
safety or patient experience, right? And there are times, many times, when you talk about things like workforce, patient experience, quality of care, that I don't think leaders should be putting financial return on investments on it. And I'm not saying that naively. I mean, I've run big organizations. I'm saying that because there are times that you do things because it is the right thing to do. You do things because you know that those are the intangibles that make good organizations great organizations. And that always has good return on investment. In fact, early in my career, when I was very involved in outcomes measurement, it was clear to me that you could track patient and employee satisfaction directly along with the financial results of the organization. In other words, you have satisfied patients, you have satisfied employees, your organization is going to do well. And it's the reverse is the case. And so I think sometimes hospitals and leaders overcomplicate things with these financial return on investments. It's not to say that you don't have to have your eye on the budget. We all know that. But there are many times that you should do things because it's the right thing to do.
I love that. I think that summarizes it in an amazing fashion, because trying to put everything into, a ROI calculation, especially because, with the changing macro environment, is what a lot of people tend to do. But I think there's a core to some of these things that is just more important, and you're almost diminishing the true value and the driving force behind doing these things when you start to, put it into a model like that. We have 2 minutes left. Olivia, do we have, I think we can do one question.
Yes.
From the audience. We'll be able to follow up on additional questions as well.
Yeah, exactly. We have some questions coming in, but one of the listeners raised a very interesting question, which I think is also very relevant to the last point you mentioned, tying back the ROI, which is not necessarily the best KPI. Then what are the most important KPIs that we can apply to achieve the quality of experience for both staff and patients?
When you're evaluating the success of any organization, I'm a believer in a balanced scorecard approach. So you have to take a look foremost in healthcare at the quality of care. You have to look at the patient experience. You have to look at the employee experience. You have to look at the financial experience. And when you look at the combination of those factors, you can see how the organization is doing. Sometimes people add growth or, new patient acquisition. That to me is not necessarily essential unless your organization has a real opportunity for growth. But the reason why I think many hospitals have a challenge of knowing how they're doing and bounce between, we're doing well financially, one quarter we're not doing well financially, we've had some changes in our quality scores, is because they don't have simple measurement tools. And that's one of the things I think the for-profit industry has. They have a stock price. And so what I like to do is I like to create a single index, call it the Dow Jones Industrial Index for a hospital, that is composed of multiple factors in these balanced scorecards, so that everybody in the organization can see how that organization is doing. Today, if the market is up or down, if you follow the stock market by looking at the Dow Jones Industrial, and hospitals should be able to simplify it that way with these KPIs that roll up into a single index. But hospitals fail short when they focus exclusively on one of those items. If you're just focused financial performance or just focused on growth, but you don't worry about your employee experience or your patient experience, that's where trouble down the road is certain to come.
Amazing, David. I think you've just, ended the session with a beautiful business recommendation idea. If we have fellow entrepreneurs listening in, I think there's a lot of, a potential on building kind of tools or products to, enhance these things more holistically. But we're out of time. David, it's been a pleasure. I know you're traveling. We'll let you run. Olivia, thank you so much for hosting, and anybody else with questions, feel free to follow up, and there will be a recording, I think, available very soon.
Thank you very much.
Right. Thank you.
Bye-bye.